Morning, morning everyone. Hopefully you can hear me today. I've turned on my microphones and everything. Let's just pop my chat on. Yeah, it looks like we've got a few people in. That's good. If you want to just drop me a message just to make sure that everyone is still alive and you can hear me. Looks like I've got a few in the room. Cool. So I'll just wait for those to come through. So yeah, welcome back. It's a nice picture. Welcome back. Hey, here we go. Right, here we go. We're getting a few through now. Good to see you, Tris. Hi, how you doing, guys? Good morning, morning. We've got a few in. Good. Everything is working. That's good. What a place to start. What a a PowerPoint to start on. I've just pressed the wrong button. It's supposed to be starting on that one. Something about Y fronts. So we are gonna do a little recap from last week. Good morning, Becky. Good morning. Got a few in today. Yep. I'm going to do a little recap from last week. And, oh. I have no idea what this means. New venue, mini showroom while Michael the Mini is getting a spruce up. Okay, I'm guessing your car is called Michael. Which which is a bit disconcerting, really. Okay, so we're going to do a little bit on the where we left last week, and going to add on a few things. And there are what you'll notice with all the anatomy videos, and if you look online as well and have a look at any dissection stuff, and even when you're looking on a cadaver. So if you get to come to the labs, you'll find it really difficult to find cutaneous nerves. So if you remember last week, we did a little bit of a recap on that. So we've got motor nerves that go to the muscles. We've got articular branches of the nerves which go to the joints. So the capsule around the joint, the synovium, all that kind of area. And then we've also got the sensory nerves that supply the sensation to the skin. So the cutaneous nerves, anything with cutaneous in is to do with the skin. So that's why subcutaneous is under the skin. That's basically where that comes from. So so we've got what you'll find is on the cadavers is that the cutaneous nerves, they aren't preserved basically when you do dissection, and the only way that we can see them, as far as I know, is through staining. So if you stain and use different dyes on different tissue, then different parts of the tissue will then become visible. So what they do is they'll stain certain parts of the body to have a look at where the density of certain different tissues are, and that's where we follow the pathway of cutaneous nerves. So that's not really done in dissection work. Okay, so you usually won't see unless they use certain techniques like the plastination stuff that von Hagens does, Gunther von Hagens. He uses a chemical that dissolves everything around the nerves, and then all that's left is the nervous system. So there are certain techniques that you can use, but they're not normally used. Good morning. So we've got Michelle, we've got Al, and we've got Julian. Good morning, everyone. So yeah, we're gonna just finishing off, a little bit of a recap what we did last time, and so we covered the femoral nerve, the obturator nerve, and the sciatic nerve, and we've done that before. So I'm not going to go over those again. I'm going to add on the gluteal nerves, which is where we left last week, and then some of the other sensory nerves that supply the skin around the pelvis, into the genitals, inner thigh, kind of that sort of area. So then that kind of finishes off those regions before we then move on to the blood supply. So we had a look at this last time. These are the quadrants of the abdomen. So if you kind of draw a grid like a tic-tac-toe on your belly, then this is what it will look like if you label it up. Let me just get rid of that so you can see. So we've got different sections of the abdomen. So obviously this is the person's right side, but obviously the left as we look at it. So similar to the heart, obviously the right atrium, right ventricles on the left side as you look at it. It's exactly the same in the abdominal region. So we've got the ascending colon, then the transverse colon, and then the descending colon around that area. So what we do when we do examinations of the abdomen, and you might have had this if you've had a bad tummy when you've been to the GP or something, they will palpate each of these regions. So they'll put pressure on each of these regions. And there are different organs that are in each region. And then well, I mean, we know that right iliac region there, that's where the appendix is. Right lumbar region, that's where your kidneys are going to be, in the bottom part of your liver. So we know the organs in that region. So if there is a problem there or there's pain there, then we can assess those regions basically. So the key thing for this section is obviously this area, because this is what we're dealing with at the moment. So we've got the iliac region, which obviously relates to the iliac spine or the ilium, and then we've got this bit here, which is the hypogastric. So obviously gastric to do with your belly, and then hypo is low, so it's the lower part. Then you've got the umbilical or umbilical area, and then the epigastric, which means upon. So you can see why they're called certain regions. So we're just going to focus on this bit for now, and you'll need those words for later. Okay, so but that's what they relate to, just so you don't get confused with what they are. So we had a look at this last week. This is one of the cutaneous nerves, the perforating cutaneous nerve. And this is a really small nerve just here. Okay, so it's coming out of S2, S3, and really, really small. And it's purely sensory. That's all it does. And it provides sensation to the medial and inferior buttock region. So it's around that area there. So basically, it's around your back passage. And if you have, and we talked about this last time, if you have someone who's lost sensation around that area, so when they wipe their bum, they can't feel it, then that's one of the red flags for cauda equina. Okay, so if you have compression of the cauda equina, which are the nerves the lumbosacral nerves that are coming down into that region, which we will cover as we move up the body. If there's any kind of compression there, then you can lose sensation around your back passage. So that's one of the areas where you might feel that it's a bit numb. Okay, so it's that perforating cutaneous nerve that may be affected. Okay, the way that I remembered the kind of regions that supply around the anus is it looks like a target. Okay, so you've got a ring around the opening, and then another ring around that, another ring around that, and then so maybe a wrong choice of words, but you've got S1 in the middle, then it comes out S2 and then S3. Okay, so as it spreads out from the opening, that's the distribution of the sensation is coming from each of those levels of the spinal cord. Yeah, it's we got taught how to test that kind of stuff, and there's no way that I'm going to be doing dermatome testing around there. So you ask the patient the question whether they've lost any sensation, because it's obviously something that we do every day. So if they've noticed any changes, then that's something to look out for. So that's the perforating cutaneous nerve, purely sensory. So remember, we had motor nerves that supply muscles, sensory nerves that supply the skin, and then articular branches that supply the joints. Okay, so those are the main ones that we're interested in. Then we looked at these as well, the gluteal nerves. So we've got a superior gluteal nerve that comes from alpha F5 S1, and this is a motor nerve that supplies your glute medius, glute minimus, and TFL. L. So you might not have heard of this before, but the glutes have got their own nerve supply. Okay, so you've got a superior nerve and an inferior nerve. So the inferior gluteal supplies your glute maximus. All right, and we looked at the video. Just going to have a look at that a second. Oh, don't do this to me. Where are we? Oh, you're joking. Here we go again. Okay, bear with me a second. Let me just see if I can load this up another way. Why does that always happen when you've got it all teed up, it's all ready to go, and then it just doesn't work? Unable to play the video. Great. Okay, bear with me a second. Let me just find it another way. Bear with me a sec. Here we go. Let's go to that one. Sorry, guys. Nerves and gluteal nerves. Here we go. Hopefully. Just get rid of that and that. Here we go. Okay, cool. So I think we looked at this last time. So let's just have another little peek at this. So that was your sacral plexus. I'm just going to pause that there. So these are the nerve roots. Okay, so what we're going to do on the next section after today is look specifically at the sacrum. Okay, so we'll have a look at all the sacral plexus, and you've got different branches of the nerve. So some come out the front of the sacrum, some come out the back. Okay. Good question, Becky. Any particular reason why the glutes have their own nerve supply? I have no idea. I would imagine that especially glute max, because of the major role it has in locomotion. But then you would usually expect important muscles to have a couple of nerve supplies just in case something goes wrong. But this one's pretty well buried. You'll see it now. So it comes off of a branch off of the sacral plexus. Let me just play this through. So there's your piriformis tucking in there. And there's your sciatic nerve. So sciatic nerve is L4 down to S3. So it's a plexus is like a plait. Yeah. So if you think about plaiting hair, and you've got all the strands of the hair all kind of making one then ponytail, that's basically what the sciatic nerve is like. Okay. Same with the brachial plexus. And so we've got all these nerves all joining together and then forming one big nerve that then splits off a little bit further down. So and that little thing there, that's your superior gluteal nerve. Okay, so it's absolutely tiny, and just a little branch off of that. And then the inferior we'll see around the back in a second. So that's going through your greater sciatic foramen. So there's your glute max. I'm going to take that away. Piriformis just there. This is your sciatic nerve just coming down here. There it is. And then you'll see the little branches. So inferior gluteal nerve just there. Okay. And then the superior one just there. So the superior going to that glute med, glute min, TFL. So you can see the direction of it will wrap around the iliac crest. So you'll know that it then supplies all of the muscles around that region. And then the muscle supplied by the inferior is glute max. Okay, so that kind of finishes off all the motor supply for that region. Now, dare I press this button? Hopefully we'll get back to the PowerPoints. Is it going to go? Oh dear. Oh, that's why. Okay, yeah, it's because I'm already. All right, okay, let's go to this one. There we go. Yay. Okay. I feel like one of those stand-in teachers today who doesn't know how to work the video player. Shows how old I am. Okay. So genitofemoral nerve. This is something that you won't see on the cadavers, and the only reason why you need to know about it is if someone has got usually with cyclists and people like that, or if they've got a problem again with cauda equina, that kind of thing. So we've got the genitofemoral nerve. Now this one is a bit of a mixture. So it's part motor and part sensory. So this one, and this is really interesting. So L1, L2. So it comes from quite high up in the uh, in the lumbar spine. So in that kind of lumbosacral area. And what it supplies, it only supplies motor for males, and there is a muscle called the cremaster muscle. And you again may or may not have heard about this, but the muscle, if I just go forward a bit here, it wraps around your testicles. So just there. So if you hear about sumo wrestlers being able to move their testicles up into their body, that is because they've got a very well trained cremaster muscle. So only males have that wraps around the testicle, and it can lift the testes up into towards the body. Okay, so that's what that muscle does, and that's coming from L1, L2. But it also supplies sensation for both male and females in the upper thigh region, so around this area here. So again, if someone's getting weird sensation in the groin, but it's a loss of sensation, then that could be part of the nerve that's been affected. In females, then the labia majora and on the pubis as well, and then for males, the front of the scrotum. Okay, so again, it's all of those questions that are a bit weird to ask, but there may be some kind of cord compression if you've lost sensation around the genitals. There are some other, especially with cyclists, more common nerves that they can impinge if they're lost of sensation around that area. So that was your cremaster muscle. Let me just and here we go. So this was the reason why I showed you the diagram of the abdomen split into 9 regions, and we've got the ilio hypogastric nerve. So hopefully, knowing what you've seen from the previous image, this one might make a bit of sense with where it goes. So it's L1. Okay, so it comes from that L1 region, purely sensory, and it supplies the skin above your waistband. Okay, so that kind of region around there. So you got that red band here, and then you've got another one just underneath it, which we'll have a look at in a sec. That's your ilioinguinal nerve. Okay, so a little bit lower. So you've got the iliohypogastric, which is just above your iliac crest, and then the ilioinguinal, which is a little bit lower than that. So let me just show you that one. Buttons up, here we go. Okay, so ilioinguinal, and there it is there. So wrapping all the way around and then following the line of that inguinal ligament or inguinal ligament. So it runs towards the genitals, runs underneath the iliohypogastric nerve. Purely sensory. And this one again is sensation towards the genitals. So we've got sensation of the genitals up at L1. Yeah. Which is, I don't know, it was interesting for me when I first found out about that. So because you'd imagine that it would be kind of in line with whether it was, so maybe in the sacral area, but actually they come up all the way from L1. So it's yeah, there you go, if you're interested in that kind of thing. And this is a really interesting one. So again, if you've got loss of sensation on the buttocks, so the gluteal area, there are specific nerves that supply the buttocks. So the gluteal cutaneous nerve, they're often called, but the old name for them is the cluneal nerve. Okay, so the cluneal nerve supplies your buttock region, and again, upper lumbars. Okay, so if someone has some kind of irritation or problem with the upper lumbars, then they can lose sensation around the buttocks or the genitals. Okay, so it doesn't have to be a cauda equina problem, but it might be. And this is where knowing the nerves kind of gives you a bit more information with your clinical reasoning. So with the cluneal nerves, there are 3 of them, or 3 branches of them. You've got an upper, a medial, a medial, an intermediate, and a lateral. Okay, so one that's a little bit higher there, one that's in the middle, and then one that's a little bit lower here. It kind of wraps around that PSIS area there. So these supply all of the top part of the buttock. So this is the superior clineal nerve, three branches: middle, intermediate, and lateral. Okay, and again, there are no cadaveric images of this kind of stuff. Okay, then you've got the middle one. This comes out a little bit lower. So this is sensation over glute max, and you can see it just poking through the back of the sacrum. So if you think about when we saw the sciatic nerve, that was coming out the front of the sacrum. So we had anterior branches, and we've got some posterior branches that come and supply the skin around the back of the buttocks as well. Okay, so that's your middle clineal nerve, so S1 to S3, and then we've got a lower one, which is an inferior. This is a branch of the posterior femoral cutaneous nerve, and we've seen that before. Okay? And this is sensation of the skin over the bottom of your buttocks, so around your ischial tuberosities. So the whole buttock region is supplied by three cluneal nerves, and the superior cluneal nerve has three branches that goes over the top. Okay, and splits there. So there's a lot going on, and then if we this is a nice image actually, or a couple of images. So you can see superior clineal nerve there, the middle one there, and then the inferior there, and then your posterior femoral cutaneous, which supplies the back of the thigh. So all of these, their role is sensation of the skin. So if someone has lost sensation around the buttocks, it doesn't necessarily mean they've got sciatica, like a nerve root compression of the sciatic nerve. It can be other reasons for it. Okay, so this is why that people often they may go for nerve conduction tests, and when they do the nerve conduction test, they're absolutely fine, but they've got a strained sensation, which may be coming from one of these nerve roots. Could that be confused with piriformis syndrome? Yeah, can be. Yeah, yeah. It depends on. Yeah, it depends on what the kind of symptoms are. Usually, the deep gluteal syndrome. So, because we don't know if it's piriformis, so all those muscles around that region, it's usually like an ache. But there may be some referred symptoms as well. But this is the thing. I mean, we haven't even really covered these. You can get something. So we've had a look at dermatomes, which is what these are. Okay, so these are skin maps, basically. What we haven't looked at is something called a sclerotome, and so the sclerotomes are referred pain maps coming from the joints. So the joints can refer in similar kind of fashion to these. Okay, so we've got all these different layers of referred pain. So it's nowhere near as easy as we think it is. When we go, oh yes, it's got to be that. It's very, very difficult to identify things. This is a good one. That's a great question there, Stevie. This is a really good one for cyclists or people who do spinning, that kind of thing. So you might have heard of the pudendal nerve already, but this is one that comes out S2 to S4, and then it travels underneath that sacrospinous ligament, underneath the piriformis. It pierces through the obturator muscles, and there's this Alcock's canal just here. I'm just going to move me out of the way. And then we've got a perineal branch of the pudendal nerve, so coming around the front here. This is a really common entrapment point for cyclists. Okay, cyclists especially. So good question, Becky. Let's just pop this up. So, are nerve conductivity tests specific to certain nerves? I wrongly assumed a nerve conductivity test all nerves in the given region. They will be for the main motor nerves. Yeah, they'll do dermatomal tests like we would for sensation, but the motor tests are the nerve conduction tests, as far as I know, are for the motor branches, because they're looking for the contractility of the muscles down to that region. Yeah, I don't know whether there's anything that it will specifically test the cutaneous nerves other than dermatomal testing? That's a good question. So yeah, let's have a look at this. So pudendal nerve, if you remember DMC, not run DMC, just DMC, because the pudendal nerve does this: defecation, going for a poo, micturition, going for a wee, and then copulation. Hopefully, you know what that is. So we've got DMC, that's what your pudendal nerve does. Okay. And if you have a problem, then it could be one of these things. Just move me over here. So we've got these 5 different subcategories of pudendal nerve: cyclist numbness. Okay, so if you deal with cyclists, then this might be something that you might come across. So we've got these different categories of pudendal nerve entrapment sites. So we've got in the sciatic notch, so where the piriformis is, the ischial spine and sacrospinous ligament, actually, the obturator internus muscle, the obturator internus and the piriformis, or then distal or on the distal branches of the pudendal. Okay, so these are the 5 entrapment sites that have been categorized for pudendal nerve issues. Another question here: is the impingement in cyclist spinners caused by a position that they're in on the saddle, or could it be encouraged for them to sit higher, lower, further, closer? It can be a combination. It may be an anatomical thing, so they have anatomical variations around that region. It may be a positional thing. It may be a compression problem. It could be the position that they're sitting in, so their bike fit. There's a whole host of things that it could be that could contribute towards the symptoms. Yeah. When I've seen this, unfortunately, the person had prostate cancer. So there can be other reasons for numbness in and around that area as well. Okay, so again, just to throw that into the works, there's another thing. Cool. Okay, so that's all the nerves. Okay, where are we at in terms of time? Oh, got loads of time. Good. Okay, so yeah, so that's all your motor nerves, all of the sensory nerves, and we've also had a look at the articular branches of those nerves when we looked at the nerves a couple of weeks ago when we first started. So let's have a look at this now. So we're going to have a look at the blood supply. Hopefully I'll be able to get my videos up. Let's just press on that button. Is it going to work? No, I have to do it another way again. Cool. So we've got blood supply for the hip and the pelvis region. Okay? And if you remember what we did previously, so this is what we looked at before. So at the knee, we've got one main arterial blood supply, which is the femoral artery. And if you remember, there's an adductor hiatus, so a hole in the adductor magnus muscle, and the femoral artery travels on the front of the adductor magnus, front of the adductor brevis, all of those muscles. And then there's a little gap in the adductor magnus, and then it goes through that gap and then behind the knee. And when it goes behind the knee, it then becomes the popliteal artery. And then that then splits into the various arteries for the foot. So we've tracked it from the foot up into the knee where it's popliteal. Now we're up into the hip, which we've had a look at before, where it's the femoral. So there's like another question here. For cyclists, it could be changing saddle type can ease the pressure. Yeah, I mean, I know that I've seen those ones with the holes in, so that you've got the seat, the normal shape of the seat, and then it's just got a gap in the middle of the saddle. So that there's less pressure. It's similar to the compression you'll get with cyclists with the ulnar nerve down into the little finger when we looked at the hand and wrist. So you've got Guyon's canal in the wrist, and if you put pressure on that, then it can make your little finger go numb and your ring finger, and it's exactly the same in the pudendal nerve as well. So if you're putting pressure around that region, so that would affect the obturator muscles and the around the piriformis region, then that can just make your bits go numb, basically, and you just move position, change your seat. Similar to if you're sitting in a position for ages and your leg goes a bit dead, and then you just need to move around. So yeah, there are lots of things that you can do to alleviate the pressure in that area. Good. So at the knee, yeah, we looked at where it came from, the thigh, so femoral artery, and then down into the popliteal artery as it goes past the knee. So it's exactly the same vessel. It's just given a different name as it goes through, and that's exactly the same here. Okay, now this looks like a mishmash of networks. So let's have a look. So the blue bits are obviously veins, because they always are, and then the red bits are always arteries. So hopefully you might have heard of some of these before. So the artery coming down here, this is the abdominal aorta, or sometimes called the descending aorta. So that's the aorta just there, and then that one there is your inferior, because it's below vena cava or vena cava, however you want to say it. And so this one carries deoxygenated blood from the legs back up to the heart to go and get some more oxygen, and then this one carries oxygenated blood down to the legs. And if you look, they follow each other. Okay, so the blue follows the red, and then down here as well. Okay, so they've got very, very similar names. This is obviously the descending aorta, so that's its own name in itself. This is the inferior vena cava, which just means inferior big vein. And then as it splits, so this area here, that is usually around about the level of L3, so around where your belly button is. Okay, so if you put your hand on your belly button, that is basically where that divide takes place. And then you've got the common iliac arteries. So those are those bits there. So that bit there and that bit there. And that is the common iliac vein, just there and there. Okay, so they're given exactly the same names. Oh, cool. Brilliant. Thanks, Sarah. Yeah, if you could share that, that'd be brilliant. Oh, it looks like you already have. It's just that I'm not linked to it. Thank you. Thanks, Sarah. So then, yeah, you've got your common iliac artery, common iliac vein, and then they split. So this one turns into the external iliac artery, and this one, internal iliac artery. Okay, and then the veins are exactly the same, but just a vein. So external iliac vein, internal iliac vein, just there. Okay, so if we go through that again, so aorta splits here, common iliac artery, external, internal. And you think, why the hell do I need to know about all these blood vessels? Well, if you have a problem here, this is where the blood pressure is under high pressure just here, and then it kind of hits that divide and goes down both legs. And it's at that point where there's a lot of turbulence in the blood. And if you've got poor nutrition, poor lifestyle, you start to get furring of the arteries, and especially furring around areas where things divide. So like this, and under high pressure. So you can get a bit of buildup of plaque in these areas here. And then if you imagine the heart is trying to pump this blood through, and then because of the plaque buildup, it gets harder to pump it. So what happens? The heart has to work harder to force it through. So the blood pressure increases. Okay, so this is one of the key areas where there may be some kind of cardiovascular disease in people who have problems with their cardiovascular system. So what can eventually happen is, if you've got a blockage here and a blockage here, so you've narrowed those common iliac arteries. Now the descending aorta is really trying to force blood through to get blood to your legs. So you have someone who, when they're just walking down the street, their legs get knackered and they need to rest. And then once they've rested for a bit, they obviously the amount of blood going to the legs has decreased, So the heart rate doesn't need to be as high, and then it gets to the legs, and then they can move again. Okay, so after about a minute's worth of rest, then they're okay. But if this is continuing to happen, so they're walking down the street and then they have to rest every 5 minutes because their legs are really aching, there may be a problem with the iliac arteries. And because the force pushing of the heart pushing through those arteries, that region, so literally just there, can start to balloon, and you get what's called a triple A. So it's an abdominal aortic aneurysm. And the only way I can describe it is like when you've got one of those really long balloons at a party, kids' party, and you're blowing it up, and you really have to blow hard, and then all of a sudden the end gets filled with air, and then you're able to blow the rest up. That's basically what the aneurysm looks like. So it looks like a bit of balloon has gone whoop, like that, and then that part of the aorta then becomes weak. So if the blood pressure continues to increase, you can get back pain, lower back pain, and if that bursts, you'll die in about 3 minutes. So it's something that is called a silent killer, and the more people that know about it, the better. Usually men in their 50s, smokers, drinkers, overweight, and you put the leg symptoms, the leg achiness, down to the fact that they're just a bit unfit. But actually, they may have this triple A. So it's worth sending them off to their GP with their symptoms so that they can get a scan. Okay, so just something to again, another something horrible to think about when you're dealing with people, and then this is the supply for the hip as it comes down the hip. So this is where we were just a second ago. So that's your descending aorta. Then you've got the common iliac artery. Then it goes internal, external iliac arteries, and then when it passes underneath the inguinal ligament just there, then it becomes the femoral artery, which is the one that we've seen before. Then the femoral artery splits into two. So we've got a deep or a profundus. Sometimes it's called the profundus. So femoral profundus. And then the normal femoral artery, which is that one there. And then as that goes through the adductor hiatus and behind the back of the knee, that is then the popliteal artery. Okay, so let's just go through that again. So abdominal aorta, common iliac artery, internal iliac artery, external. When you get to the ligament, inguinal ligament, it then becomes the femoral artery, which then splits into a deep, and then it carries on as the femoral, and then it becomes popliteal. So your whole leg is supplied by this vessel here, and we talked about that before. Okay, so when we've looked at the foot and ankle, and we've looked at the knee, if you have any kind of blood supply issues to the knee, to the thigh, to the foot, to the ankle, anything like that, it is coming from this point. If there is a problem, okay, yeah, that's something to look for. So as it becomes the femoral, it splits into deep femoral, so supplies all of the quad muscles, and then you've got these circumflex arteries, which go basically they go around. So circumflex. We've got medial, which comes inwards, so supplies the genitalia, and then the inner part of your thigh, and then the lateral circumflex supplies the head and neck of the femur, as does the medial actually, and also your like sartorius, that kind of region. Okay, so we've got different blood supply on different bits of that artery, and I'll hopefully be able to get you the videos in a sec. Let me just grab you those. Okay. Sorry, it's going to take a little bit longer than usual. Here we go. Okay, let's have a look at this first. Just get rid of that. Here we go. Okay, so this is a right leg. So right thigh, it's just had the skin removed and nothing else. So all of this yellow stuff is fat, and there's the skin. So this is subcutaneous fat. And you can see that one there, that kind of line there, that is your saphenous vein. Okay, so let's have a look at that. So there's your ASIS up there. There's your knee down there. And then this is the long saphenous vein. And we've looked at the saphenous artery before. So there it is, all the way traveling up right into the groin. If anybody's had any work done with varicose veins, then you'll know all about this one. Okay, so there's your inguinal ligament. So that line across there. And then we've got this area here. These nodules here, those are your lymph nodes. Okay, so your lymph nodes drain into your venal system. Okay, so you can that's why they're really close. We've got these branches draining off from the skin here. I'm glad you think so, Stevie. I do too. So these are all the branches feeding into that saphenous vein. Okay, so all of the deoxygenated blood coming back into this area. So there's your lymph nodes, inguinal lymph nodes. And then you can see it going through that inguinal ligament area there. So that'll pass through. If you remember the femoral triangle, well, here we go. Here's your femoral triangle. It says sartorius just there. So you got vein, artery, and then nerve just there. Okay, so that's your navy, nerve, artery, vein, and then Y fronts. So there's the vein. That's your long saphenous, and then we've got the femoral vein, and they both join together. And then when it passes through the inguinal ligament area, it then changes from the femoral vein. So there's the inguinal ligament, there's your pubic bone. As it passes through underneath there, so over the inguinal ligament, it's called the external iliac. Yeah, so it's exactly the same as the artery. So there's the artery just there. We'll have a look at that in a sec. But there it is there. So this is it tracking it up now. There's your psoas. Another reason not to go prodding around in psoas. So internal iliac just there. And then where they join together, that's your common iliac. Okay, so there's your left, there's your right, and then that's the inferior vena cava just there. So the inferior vena cava is the main blood supply, or main blood vessel, main vein going back to the heart from the lower extremity. Okay, cool. Right, let's have a look at the next one. So that was all the veins. Let's have a look at the arteries. Here we go. Okay, cool. So just give you a bit of an orientation. So there's your abdominal or descending aorta, and this is where it splits. So remember I said that was around about L3. Let's just follow that down. So you've got common iliac arteries. So there's the right and the left. And then see that little branch off there? That's your internal iliac, external iliac. And then the external iliac becomes the femoral, just there. Inguinal ligament again, and it's literally just from flipping over. That's where it changes name. So we've got circumflex arteries. So one there and one there. So that supplies your perineum and the genitals. Deep femoral is just there. So it splits. So it carries on as the femoral down here, and then goes into the deep just there. There's sartorius, and then below that we've seen before. So that's where we get to with the knee. So if you want to follow that through with the knee, then go and have a look at the knee videos. And then let me just bring this one up. So then let's show you that split. So we've now got the femoral artery here. These are the circumflex arteries, just there and there. And then that one just tucked away there, that's your deep femoral. So let's have a look at that. So there's your femoral, there's your deep femoral just tucked behind it. Sartorius there. And we're just going to take some things away. There you go. So you can see how it feeds the muscles. So this is your deep femoral. So you've got medial circumflex, lateral circumflex. So, and they supply the regions that they go to basically. And then pectineus, adductor brevis, adductor magnus, your rec fem, all supplied by this deep femoral artery, and it all comes from that external iliac artery. Okay, let's just have a look at that again because it's only a few seconds long. So these vessels here, these ones are quite superficial. Okay, so literally just underneath your inguinal ligament, just underneath the skin. So they're quite close to the surface. and then the deep femoral, which we'll see in a sec. So that's your femoral. They're going to take that one off. So they'll remove that, and there you go. You're just left with the deep. And then if I just pause that there. Okay, there you go. Okay, so we've got this medial circumflex, so supplies your adductors, obturator externus, gracilis, your hamstrings, and the sciatic nerve. And we'll have a look at that in a sec. Also the head and neck of your femur. So the blood supply to the joint comes off of this branch as well. And then the lateral supplies sartorius, quads, TFL, and then the head and neck of femur going around the other way. So we've got these two circumflex arteries that circumnavigate the femur. Okay, all the way around there. Cool. Okay, let's have a look at the last bit, which is this one. So this is the superior superior and inferior gluteal nerves, so gluteal arteries. So very, very similar positioning to the gluteal nerves that we saw before. So there's your main artery. Okay, so iliac artery, internal and external. So we followed this route just a minute ago, going under the inguinal ligament. We're now going to follow this one. So this is the internal iliac that gives a branch off for the superior gluteal and inferior gluteal arteries. There's your piriformis. So again, the arteries go over the top and bottom, so similar to the nerves. There's your glute max. Just going to take that away. There's a really fascinating bit in a minute. So glute med, glute min. There's your piriformis just there. Yeah, glute med and glute min underneath. There's your sciatic nerve. Now, if you have a look around this region here in a second, so just around there, what you'll see is a blood supply from this inferior gluteal nerve just here to the sciatic nerve. Okay, so obviously your nerves need blood. There's the superior. Okay, and there's the inferior. And look at that branch there. Yeah, feeding onto that all the way down that sciatic nerve, and then into that looks like the iliac ischial tuberosity area. So this top one here goes towards the piriformis. This one here, gluteal artery, below the piriformis. Sorry, above the piriformis and below the piriformis. But can you see this branch here? Okay, so there's the superior gluteal artery, little branch off, feeding that piriformis muscle there. Okay, so and that's how your muscles and nerves get their blood supply. Cool. That's it. All done. It's actually hip and pelvis. Again, way more detail than we covered last time. We've gone into all of the cutaneous nerves around the whole buttock, genitalia area, around the waistband, and you know where they come from now. So if there are some issues with the sensation, then you can work out whether it's coming from those cutaneous nerves. Again, if you've done neurological testing before, those are the kind of things we test for. I'll see if I can find some information out about nerve conduction testing and what they look for. I think it's only motor nerves, but I may be wrong. So I'll find out for sure. But yeah, it's always fascinating and a bit mind blowing when you get into the nerves and the arteries, because it's something that we don't usually cover. I don't know either, to be honest. So I don't know where it comes from sometimes. I think, and that's why lower back pain is so difficult to pin down. Exactly. Yeah, exactly right. Yeah, it's. I mean, in fairness, with all that information there, I with my patients, I'll do an assessment, and then it's on reflection after that assessment that I'll start thinking about some other things if they're not improving, because common things happen commonly. Yeah, so if you see someone and you think, oh, that's probably that, let's go down that route. And that's the thing with the kind of stuff that we do in using fitness or therapy world, or rehab world rather than fitness, is that we're trying our best to do no harm with someone, and we'll give it a go, knowing that it will probably help, but with a view that we don't want to make it worse. And if it doesn't get any better, then we just need to rethink our plan. And yeah, like I say, common things happen commonly. So most things kind of clear up, and it's like, oh yeah, and you look amazing. Wow, this person knows what they're doing. But sometimes it's a bit trickier, and you do have to think about some of these things and just reflect on it. And it, yeah, it doesn't happen all the time. Certainly not straight away. But yeah, but you have to be honest with people. I think that's the thing. If you do, you have to be honest about the processes, and like Stevie said, all of those things that contribute towards those symptoms. And that's what clinical reasoning is about. So if you understand all of those layers that go into the things that can feed into symptoms in that area, and you're basically just going through the layers, ticking them off, right? Test that, test that, test that. That's all we can do. That's all we can do. Cool. That was a good one. Sorry, it's a bit longer than planned. And next time we're going to be focusing purely on the sacrum. So I used to do lumbar sacrum. We're just going to do the sacrum because I want to go into a lot of detail on the sacral plexus. Okay, so do all the bony anatomy, revisit those muscles that attach in. So a bit of a recap on some of the things we've done. But yeah, specifically about the nerve supply coming out of the sacrum. So we'll have a look at that. Cool. Thanks everyone. I'll see you next week, 10 o'clock.